This
respectful of
conference
people's
will
time.
now be recorded.
Excellent. I want to welcome commissioners and members of the public. This meeting is another remote-only commission meeting. Given that this is a remote-only meeting, additional ground rules will apply. I'll begin the meeting with a roll call of the commissioners. During the meeting, I'll ask the people speaking identify themselves before speaking. That way, commissioners and members of the public will know who is talking and have the same knowledge as if the meeting were in room 100. We're using GoToMeeting for the first time today. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask that commissioners and others mute their phones when they are not speaking. For this meeting and at future remote-only meetings, we will post documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them and read them before the meeting begins. We'll continue to provide advance notice of how to dial into the meeting by posting that information on the Commission website homepage and on our various social media challenges. I will now call the roll. Commissioner Bandari?
Yes.
Commissioner Boyer?
Here.
Commissioner Boyle?
Here.
Commissioner Dorden?
Here.
Commissioner McCarthy yet?
I haven't seen you.
Commissioner Metz yet? Nope. Commissioner O'Connor? Commissioner O'Connor?
He was connected earlier because I spoke with him.
Commissioner O'Connor, if you're trying to speak, you're muted. All right. Is there somebody who could reach out to him and see if we could address a connection issue there? Yeah. Commissioner O'Grady?
I see him.
Commissioner O'Grady? See you, we can't hear you. All right, again, if we could reach out to Commissioner O'Grady. Commissioner Reimer. Commissioner Reimer.
Are you on?
So Commissioner Reimer was on, we said. Don't
hear.
Say again?
It's a little hard to tell, but I thought Commissioner Reimer is on video.
I can't, the videos, the pictures are too small for me to tell.
Right.
Commissioner Sargent, I hear you.
Right, I'm here.
Commissioner Thomas, I see you. Can you speak?
Can you hear me?
Yes, I can hear you. Good. And Commissioner Wang, I heard you previously. All right.
I'm right here.
Any other commissioners? Great. Any other commissioners join the call?
Let me try. I'm going to hang up and see if we can call you out. Okay.
All right. I'm going to move forward in the agenda, and we will work on the commissioners who are online but unable to be heard in the meantime.
So,
Levon, go ahead, Ben.
Can we call out Dr. O'Connor? Can he hear? He is online, but he says we can't hear him. He can hear us.
Only thing I recommend is maybe if Commissioner O'Connor, if you can hear, maybe hang up and dial the number again. There is no audio pin or anything, so it's a simple, straight telephone number, and then you put in the GoToMeeting ID.
But if you don't have an audio pin, you won't be able to talk. You get muted. That was a problem I ran into until the beginning.
Okay, I just sent him what is listed as an audio pin, so he should have it.
Okay, good. the first item on the agenda is approval of the minutes, which requires a vote. And with several commissioners not being able to communicate right now, I guess, can they email the votes in?
Mike, do you have the audio?
We're trying to get him connected now. I still don't see Commissioner Metz.
Can we also use the chat mechanism?
Yes, absolutely. I will see the chat mechanism if they use that. Yes.
All right, so there's a chat bubble in the upper right-hand corner of your screen that you should be able to click and enter.
Yes.
And you need to make sure at the very bottom, it says send to everyone.
Right. Did somebody just join? All right.
Chairman, Dr. Pollack and Mr. Stefan, this is Commissioner Bhandari. I have a question.
Yes.
On action agenda item 6, it says action none requested. I know Mr. Stefan had sent some information, and I have some thoughts and some follow-up questions on that. So that can be done in the upcoming days or weeks. That doesn't need to be discussed at this point.
Yeah, we have some other non-action items too on the agenda, but yes, we won't. There's no vote on number 6. That's correct.
Okay, I will send the information to commissioners and Mr. Stefan in next couple of days. Thank you so much.
I'm going to go. Commissioner O'Connor is now in communication through chat. I think we're going to. I'd like to go ahead and. Do I have a motion to approve the June 18th minutes?
So moved. Commissioner Sargent.
Second.
So, okay. Who was the second?
Marcia Boyle, Commissioner Boyle.
Commissioner Boyle. So I have a motion from Commissioner Sargent and a second from Commissioner Boyle. All in favor?
Andy, could I just clarify, this is Chip, that these are the minutes that Ben sent out as corrected?
That's correct. The revised minutes that were sent out this morning is corrected.
Thank you.
Corrected.
Thank you.
All right. All in favor?
Aye.
Aye.
Any opposed?
Aye.
All right. Very good. Moving on to agenda item number 2. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Hearing none. Does the executive director have any updates? Ben?
Thank you, Chairman Pollack. I have a couple brief updates. Staff continues to work from home with staff attendance at the office limited to 5 staff persons or less, with others required to call in before they arrive. As most of you know, Maryland has continued to enjoy some success in flattening the spread of the pandemic. But since July 4th, we've seen our moving averages on both cases and hospitalizations creep up slightly, demonstrating the need to continue to be extremely alert and social distance, wear a mask, and if ill, quarantine or exposed to quarantine. I think the next couple weeks will be very critical for what the future portends for the state, given what we've seen in many southern states that opened very abruptly, and as a result had significant outbreaks. So we'll keep our fingers crossed. I did want to share some, I think, very positive news regarding personnel. At the start of the pandemic, in response to concerns about budget implications, Governor Hogan had issued a hiring freeze. At that time, we had 6 positions that we were recruiting for. All 6 of those positions were frozen, and early this month, the Department of Budget Management informed us that we could go forward with hiring 5 of those positions, one of which we've already hired, and we expect that person to begin work in August. She will be in the Center for Health Facilities Planning and Development, working with Eileen Fleck's team in development of state health plan chapters and review of certificates of ongoing performance. In addition, over the last 6 months, I've had several conversations with Secretary Neal about the burden that the Healthcare Commission has borne over the last 3 years in terms of loss of PINs. He has promised to help us, and he has recently authorized a transfer of 1 senior level longstanding trusted staff person in the Department of MHCC. Tracy DeShields will join the Commission on July 29th, reporting to me, but assigned to work with specific centers on a project-by-project basis. Ms. DeShields has been with the department for more than 20 years and has held several senior public policy and regulatory positions. As I note, I anticipate detailing Ms. Shields to the Center for Health Facility Planning to assist with state health plan chapter development, as well as some regulatory development with other centers. Ms. Shields holds a Master of Law degree from DePaul and a JD from the University of Maryland. I'm very pleased that she's going to be joining MHCC, as I've known her for many years and trust her judgment. I also want to thank Secretary Neal for agreeing to this transfer at this time. The staff continues to focus on improving our focus on race and ethnicity. As I mentioned last meeting, we are renewing our focus in improving our data systems. Certainly the most important is the all-payer claim database. In that domain, Medicare and Medicaid have longstanding initiatives to collect race and ethnicity data. And although we have requirements on private payers to submit that information, we have never been successful in getting significant volumes of information on race and ethnicity of subscribers from payers. They argue that it's difficult to collect, as many often subscribers are reluctant to provide that information. We've agreed that we are going to redouble our efforts, not only working with payers, but also considering other alternatives, including our health information exchange, to consider other possibilities for populating these fields. It is understood that there are longstanding concerns among residents of the state, particularly minorities, about the implications of coding race and ethnicity, as it might compromise their access to care or lead to redlining regarding rates. But I think we need to be more creative in filling out those fields, working with payers, but also being emphatic that we expect that progress made to date is not the progress we can accept in the future. We are also, and we'll be talking more about this today, redoubling our efforts to gather information on the Maryland health practitioner workforce. Beginning in 2013, then Secretary Josh Sharfstein had asked the Healthcare Commission to work with boards to improve their licensure and relicensure applications to capture race and ethnicity of practitioners. At that time, we made progress, but in the last few years, that information has not been used heavily within the department by MHCC. And what we plan to do is working with the department and the boards to redouble efforts to gather that information. I think everyone recognizes that having a health professional workforce that more closely mirrors the Maryland population is one mechanism through which we can ensure that all patients are able to access and feel comfortable seeking care. And lastly, we've continued to plan to focus some of our own data analysis on these, both from the standpoint of intramural and beginning to think on contracts that we may issue extramurally to focus on access for all Maryland residents. More to come on that in the future. Our APCD contract, which will be recompeted this summer, we plan to add a focus consistent with the challenges we face in collecting race and ethnicity from private payers in their submissions to that important data system here in the state. That concludes my update. Happy to take any questions.
Any questions for Ben? Hearing none, I have one announcement. As is typical for the commission, we typically do not meet in August. Ben and I talked about this yesterday, and given the potential for a second surge or additional activity later in the year that could disrupt our agenda further, I thought it would be best if we could reserve the August 20 date for now to have a meeting in the event that we find that there is sufficient material and sufficient action items ready to present, particularly with regard to CON. We've been behind in the CON process and applicants have been waiting. And it would be nice if there are applications that are ready for us to approve, if we could have a quick meeting on August 20th electronically to approve those. If it turns out that we don't have much ready, we would postpone and move till September. But it would be nice not to have things backing up on our docket as we move into September. So I guess what I'm asking is if commissioners would be willing to hold the August 20 date, and Ben and I would commit within the next 2 weeks to determining whether or not we need to use that date. Anybody have any objection to that right now?
I do not.
Great. Thank you. Before I move on, do you have any update on connectivity? Has anybody else been able to join, Levon?
I have not seen Commissioner Metz or McCarthy yet. I think Commissioner Brady looks like he should be able to talk.
Yes. Can you hear me now?
Yeah,
I can hear you now. All right.
Great. Going back on mute.
Fantastic.
All right. So we look good now.
All right. Excellent. Okay. Before we consider action items today, I want to remind commissioners that if they wish to recuse themselves on any action item, they should inform me. Since this is a remote meeting and a commissioner cannot move to the small conference room, commissioners who are recused should remain silent and mute their phones. If there are no questions, we'll move to agenda item number 3. The next agenda item is for consideration of 3 applications for a certificate of ongoing performance for PCI services for Anne Arundel Medical Center, MedStar Franklin Square Medical Center, and the University of Maryland, Baltimore, Washington Medical Center. The applications will be discussed together, but there will be a separate vote on each application. Eileen Fleck, Chief for the Division of Acute Care Policy and Planning, will present the staff's report and recommendation on this application. Eileen, please proceed.
Good afternoon, Mr. Chair and Commissioners. The Commission is required by law to periodically certify the PCI programs are meeting performance standards established in regulations. And so if I could have someone advance to the next slide. Thanks. So on this slide, we have a summary of the performance standards, and these include data collection, institutional resources, quality assurance activities, patient outcome measures, physician resources, volume, and patient selection. The standards differ slightly whether a program has both elective and PCI services or if a program just has PCI services. Staff also notes that the performance standard for risk-adjusted mortality rates is not applicable to the review of these applications because the regulations were revised to reference a different benchmark, the national average, and the first applicable review period will be calendar year 2019, for which we don't have data yet from all of the hospitals. The staff reports do contain information on how a hospital would have performed on that benchmark, but the information is there just for informational purposes only. Next slide. So first, Anne Arundel Medical Center, in terms of its performance, as shown on this slide, the hospital is meeting the requirement for primary PCI services to be available.
Eileen, can I ask you to stop for a second?
Yes.
Are there any questions on the standards before we move forward? Okay. Hearing none. Before we move on to the discussion of Anne Arundel Medical Center, Commissioner Dorden has informed me that he will recuse himself on this agenda item number 3A on Anne Arundel Medical Center. So, Eileen, can you proceed?
Yes. As I was saying, Anne Arundel Medical Center is meeting the requirement that primary PCI services be available 24 hours per day, 7 days per week. There was one planned interruption during the review period that lasted for an hour. The hospital also meets the door to balloon time benchmark on a rolling 8-quarter basis for all periods, with between 92% and 96% of cases having a door to balloon time of 90 minutes or less. The program is performing well over the PCI volume target of 200 cases. The hospital performed between 369 and 447 cases annually between 2015 and 2019. And in terms of the primary PCI volume, the hospital is also exceeding the minimum volume expected, with volume ranging from 113 to 149 cases annually over the review period. The physicians are all performing 50 or more PCI cases on average annually if the physician provided PCI services for at least 24 months of the review period. Next slide. As shown on this slide, Anne Arundel Medical Center performed the required external review of elective PCI cases and exceeded the minimum percentage of cases that must be reviewed, which is only 5%. And the hospital reviewed the minimum number of cases per physician too. With respect to the requirement for individual interventionist review, the hospital reviewed at least the minimum number of cases in each external review cycle, and that was not enough to meet the requirement for 10% of cases or 10 cases per interventionalist. However, all cases are reviewed by the medical director, and there is additional internal review of cases, specifically for cases with complications or door to balloon times over 90 minutes. So through a combination of internal and external review, the requirement for individual interventionist review is met. The program only performs primary PCI on suitable patients, as demonstrated through internal or external review, and also for elective PCI cases, program is performing well there as well. There were only 2 cases determined to be rarely appropriate for angiographic criteria by an external reviewer in 2016, and the hospital reasonably followed up on those cases. No other cases were determined to be rarely appropriate for clinical, angiographic, or ACC/AHA criteria over the rest of the review period. Staff recommends that the Commission find that the hospital has complied with all standards and approve the Certificate of Ongoing Performance to allow Anne Arundel Medical Center to continue providing primary and elective PCI services. We have Stephanie Waltz, the Clinical Director for Interventional Radiology, the Cardiac Cath Lab, and other services on the line who can respond to questions. I would also be happy to answer questions.
Very good. Do I have a motion to approve Anne Arundel Medical Center's application for a certificate of ongoing performance?
Commissioner Bhandari, yes.
For a second.
I'll second. Commissioner Sargent, I'll second.
Discussion. Any questions?
So this is
Hearing
Commissioner
none.
Bhandari. So what was the criteria for two cases to be really appropriate for angiographic criteria by external reviewer? What was the logistics in that case, if somebody can explain?
So each hospital has an external reviewer, and they actually look at the images, right, the angiographic images, and there are standards. I think it should visually be at least like 70% in order to be considered appropriate based on angiographic criteria. Sometimes an interventionalist may actually measure the amount of blockage. I think that's something that can be done, but also I think most of the time people rely on the angiographic images, and the threshold is generally 70%. And so that is very narrow, right? Just focusing on the imaging, but then also there are other criteria for clinically, was it appropriate to intervene? And then also the American College of Cardiology and the American Heart Association have guidelines which we've adopted to be used. And so there are different ways to look at the appropriateness, and the angiographic criteria is specifically just looking at those images and the amount of blockage.
Thank you.
Are there
So
other
it is
questions?
possible.
Is somebody else speaking? Okay. I have a motion and a second. All in favor of approval of the motion for the certificate of ongoing performance for Anne Arundel Medical Center?
Aye.
Aye.
Aye. Aye.
Aye.
Any opposed? All right. The certificate of ongoing performance for Anne Arundel Medical Center is hereby approved. Eileen, please proceed with Franklin Square Medical Center.
Okay, next slide, please. So MedStar Franklin Square Medical Center has maintained around-the-clock availability of its cardiac catheterization lab. It only has one room, but it has a hybrid operating room that it uses as backup. Over rolling 8-quarter periods, the hospital has complied with the door to balloon time standard for all periods, with between 83% and 86% of STEMI cases having a door to balloon time of 90 minutes or less. The program, in terms of volume, has performed between 77 and 99 primary PCI cases annually between 2015 and 2019, which is above the minimum threshold. And then also physicians performing PCI at the hospital are meeting the applicable case volume minimums for performing primary PCI at a program without on-site cardiac surgery. In terms of the required review for individual interventionalists, the hospital uses a combination of internal and external review to meet the requirement, and that is adequate. And then lastly, there are no primary PCI cases that were identified as inappropriate through the internal or external review. Staff recommends that the Commission find that the hospital has complied with all standards and approve a certificate of ongoing performance to allow MedStar Franklin Square Medical Center to continue providing primary PCI services. We have Cheryl London, Regional Vice President for the MedStar Heart and Vascular Institute on the line, as well as Don Thaxton, who's Director for the Cardiopulmonary Service Line on the phone, who can respond to questions, or I'm happy to answer questions too.
We're still looking at the Anne Arundel slide. If you could advance it, please.
I'm seeing Franklin Square
We have
on
the
my
Franklin Square slide up.
Really? Maybe mine's just slow and refreshing.
Sorry. Do I have a motion to approve the Franklin Square Medical Center application for a certificate of ongoing performance?
So moved.
That was Commissioner Dordan, I believe.
Correct.
And is there a second?
Second.
Who was that? I'm sorry.
Commissioner Boyle.
Commissioner Boyle. Okay. So I have a motion and a second. Any discussion? Hearing none. All in favor?
Aye.
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 Excellent. Any opposed or abstaining? Very good. The certificate of ongoing performance for Franklin Square Medical Center is hereby approved. I will now recuse myself on agenda item 3C. Vice Chairman Sargent will chair this action. Vice Chair Sargent, the floor is yours, sir.
Thank you. We're going to turn to Baltimore Washington Medical Center. Eileen, please proceed.
Thank you. Next slide, please. Thanks. So the University of Maryland, Baltimore Washington Medical Center has had some difficulty maintaining the around-the-clock availability of services. However, the reasons for downtime have been unforeseeable, or they reflect reasonable judgment by the hospital. So we do recommend that the Commission find the hospital is meeting the standard in terms of 24/7 availability for primary PCI services. Over the rolling 8-quarter periods, the hospital has complied with the door-to-balloon time standard, with between 88% and 94% of STEMI cases having a door-to-balloon time of 90 minutes or less. And the volume of total PCI cases performed between 2015 and 2019 has ranged from 299 to 382 cases annually. And for primary PCI, the volume of cases has ranged from 99 to 163 cases annually over the review period, both of which well exceed the target volumes for those types of cases. With regard to the physician volume requirements, each interventionalist is performing at least 50 PCI cases on average annually over a 24-month period. Next slide, please. As shown on this slide, the hospital has performed the required external review of PCI cases and exceeded the minimum percentage of cases that must be reviewed, which is only 5%. And the hospital reviewed the minimum number of cases per physician too. With respect to the requirement for individual interventionalist review, the hospital reviewed at least the minimum number of cases through a combination of internal and external review. And the hospital is only performing primary and elective PCI services for suitable patients. No cases of either type were identified as inappropriate by internal or external review. Staff recommends that the Commission find that the hospital has complied with all standards and approve a certificate of ongoing performance to allow the University of Maryland, Baltimore Washington Medical Center to continue providing primary and elective PCI services. We have Cheryl Cole, manager for the Cardiac Cath Lab, on the line who can respond to questions, and I'd also be happy to answer questions.
Sorry, some delay coming off of mute there. Why don't we start, Commissioners, with see if anybody wants to make a motion.
Commissioner Bhandari.
Okay, so there's a motion to approve the application of Baltimore Washington Medical Center for certificate of ongoing performance. Commissioner Bhandari made it. Is there a second?
Commissioner Boyle.
Commissioner Boyle, thank you. And any questions, any discussion? With that, I will call the question. All in favor?
Aye.
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 Are there any opposed?
Aye.
Great. With that, I think all in favor, none opposed. We can go on to agenda item number 4, and I can relinquish the power.
Thank you. Back onto agenda item number 4. The Where the Cost is MHCC's consumer-centric episode cost and quality initiative to increase price transparency around cost and quality difference in episodes of care among Maryland hospitals. MHCC creates episodes around particular clinical procedures or diagnostic conditions. The website shows a patient's average cost for common hospital procedures at different Maryland hospitals using commercial data from the MCDB. This update is the 3rd reporting on healthcare expenditures this year using the MCDB. Malet Nagatu, Chief APCD Public Reporting and Data Release will present. Mahi, please proceed.
Thank you. Can you hear me?
Yes.
Yes.
Okay, great. And can you see my screen?
Yes.
Yes.
All right, great. Good afternoon, commissioners. I'll be presenting the overview of the Where the Cost release for commercial 1617, which was deployed just today, this morning. So as for a background, the data source that's used for this release is commercial 2016-17 claims. Previous releases included 2014-15 and 2015-16 commercial claims as a study window. Kaiser and ERISA data are not included in this cohort. And as for the development team, we have MACC staff and Remedy Partners, which is part of Signify Health now, for the execution of the Grouper software and reviewing output results. Social Scientific Systems helped us with the development and maintenance of the Where the Cost website, and the Hatchers Group helped us with the content promotion and media engagement. For this release, a total of 10 episodes qualified, and among these 10 episodes, 4 of them were previously reported, and these are hysterectomy, knee replacement, vaginal delivery, and hip replacement. And we added 6 more. These are bariatric surgery, colorectal resectioning, C-section, lumbar spine fusion, gallbladder surgery, and lumbar laminectomy. As you can see, a total on this slide, there includes the number of hospitals that qualified for each episode. So for instance, bariatric surgery, we had a total of 13 hospitals that qualified for reporting. So for this release, we have a slight modification in the way PAC rates is reported. So for instance, for colorectal resectioning, we have PAC rates for facilities with episode volume less than 44 not showing, but both values are displayed for 9 hospitals. We also did, as a part of a preparation for this release, with the past 2 releases, and this is just to ensure that data looks accurate. And since the Where the Cost is episodic, we only were able to validate using inpatient costs, and this is using 3 reporting streams, the past 2 releases within the Where the Cost, and also the quality site, which is the Maryland Quality Reporting site. And the inpatient cost is in a comparable range. So what is new for this release? So the first one is obviously the inclusion of the new 6 new episodes, and I'll be doing a demo of the website soon, but just wanted to highlight some of the changes that we'll see in this release. So the inclusion of new episodes, and as you can see, this is the landing page, including the tile view of the episode that are included. It's not an exhaustive list. As I said, there are a total of 10 episodes that were qualified for this release. So one other thing that Where the Cost takes pride in is the selection of the photos that you're looking at right now, which are all Maryland residents. So the models for both the profiles and the profile images, the lifestyle images used across the website are all Marylanders that were recruited in the process of making this site, developing the assets for this website. So the other new addition to this release is the consumer feedback survey. So when Where the Cost was initially launched, we did a focus group to help us identify and understand how consumers interact with healthcare cost and quality. And the website has gone through 3 iterations with these focus groups so that we can continue improving the website, meaning like gathering feedback and then implementing those feedback into the website to make it more consumer friendly. So we wanted to continue that engagement. So we added a consumer feedback survey question that's going to be permanently available on the website. So and this will just help us, by gathering this information, we'll be able to tweak when we have a new release or if there are other changes that we need to make. So in the last change that we have, and I have briefly touched on this earlier, is how we're displaying PAC rates. So this new approach allowed us to report more hospitals, and by identifying a separate set of PAC rate threshold, and then being able to report cost information for those hospitals where the PAC rate was not within the threshold, but the cost information is within the threshold, so we continue reporting the cost information. So before going into this last piece, I want to go through the website demo and show you these different features that were added for this release. So Luvan, I'm going to try to swap the presentation.
All you have to do is close your presentation and open up a web browser, and then you can go to it.
I have the web browser open, so should I close this one?
Yeah, if you're sharing your screen, yeah, you can go ahead and just close the presentation.
Okay. So it's only giving me control to make you the presenter. All right, hold on. I think I figured it out. All right. Okay. All right. So can you see my screen, the website?
Yes, you got it. You're correct.
Wonderful. Great. Okay. So here is the landing page, and I briefly touched on this. So the new additional episodes are shown as in a tile format, and initially we had these 4 episodes. These are the hip, knee, hysterectomy, and vaginal delivery, and everything else are all new. And the newest addition, which is the help us improve the site consumer feedback, is a button that's gonna reside at the bottom of all the pages, and when clicked on it, it will take the consumer or the visitor of the website to this section where they will be asked a few questions of why they're looking at how they came to the Where the Cost website, and other relevant information that will help us improve the information that is displayed on the Where the Cost. And like I said, the PAC rate, the display of the PAC rate that we have tweaked a little bit this time is where in the past we only reported hospitals if they qualify both the threshold for the cost and PAC, but now if the hospital qualifies for the cost threshold, we'll continue displaying it, but then blind the PAC performance category. So that is a new approach that we use for this round. In terms of feedback, we have been able to gather feedback from commissioners, and we have incorporated those into the website. And one of this was how the PAC rate was categorized, and we were able to include that in the technical detail for under the join the conversation section, which is under here. So going back to what's next, what we're thinking of doing is moving to commercial 2018-19. So this is different than how we have cut the data study window in the past, which is we did 2015-16, 16-17. There's always a year overlap. So instead of that, we're going to use 2018-19, which means all the episodes that ended in either of those years, regardless of when it started. So it could start in 17, and it will still be included in that cohort. So that will help us also catch up with the MCDB timeline and also make the information current. So we're targeting around October 10th for this release. And the other initiative that we're thinking of doing is a trend report. Since we have 3 study windows now, we will be able to do these trend analysis and also do a different kind of flavor of report, meaning we're going to look at demographic information as well, like zip code and age, to really take a deep dive in the where the cost data that we have available now. So with that, I conclude my presentation, and I'll be happy to answer any questions.
Are there any questions for my commissioners?
This is Dr. O'Connor. Can you hear me?
Yes.
I have just one comment. Can you hear me okay?
Yep, loud and clear.
Okay. The where the cost report, excellent report, by the way, but I have a comment. I guess I can speak for the gallbladder costs that they speak of. I did take a quick look at it. A couple things. I've had patients come to me and say, wow, you make a lot of money on a gallbladder operation. I look at the costs on there, and they have most of the costs for the gallbladder there is kind of misleading because it's all inpatient costs are the majority of the cost, and yet the far majority of gallbladders are done as an outpatient. The professional fees are kind of all lumped together. I didn't know, our fees, as you know, Dr. Pop, we're paid by code. I mean, everybody gets paid the same. I guess the GBR money comes in when you divide the number of cases in GBR, and that's the cost of inpatient allocation. But the point I'm making is that number there is kind of misleading to the public. I can only speak to the gallbladder surgeries. You can speak to the orthopedic stuff, but I don't know if it would complicate things by making a more elaborate description of those costs. So those are just my comments.
So let me just a couple comments. So I believe the numbers demonstrate do not include the professional fees. They're exclusive of that. This is just the hospital cost. And you're right. It's just,
if you go to if you drop down next to it, the vertical column, it says where are these costs. It does include professional fees, and my professional fee is like less than 5% of that big fee that you see there.
So for this round, just to clarify, yes, the inpatient cost includes cost information as well, so not just the cost related to the index stay.
I assume the professional services include professional fees, right? Yeah.
Yes.
So it does include professional fees, Dr. Paul.
Yes.
Yep.
So, but these.
I see that. Yep.
So.
See what I'm saying? It has inpatient, and it's very uncommon to do these gallbladders as inpatient. That would be, and people have the impression that the surgeon is making all this money.
So this round, the information that we see are all procedures triggered in an inpatient setting. So it doesn't include any outpatient, for in this case, gallbladder surgeries. So these are all triggered in an inpatient setting.
I didn't hear you that clearly. Does the professional services include surgeon, anesthesia, and so forth?
Yes. So, but what I was saying was the episodes that we're seeing in the site for this cohort only include procedures that were triggered in an inpatient setting. So outpatient procedures are not included in this. So what the cohort is a bit different. So it's not a mix of inpatient and outpatient procedures for the actual surgery itself.
Oh,
So you just chose inpatient gallbladders. which is a very small sample of all gallbladders that are done.
Correct.
Okay, gotcha.
It will be important on the website to clarify that so that when consumers see that, they understand that this is just those cases done on an inpatient basis.
Yes. Yes.
This is Commissioner Bhandari. Is there a way where they can, as Commissioner O'Connor said, is there a way there we can further elaborate if it's inpatient, this is the cost. If it's outpatient, which is most of the surgeries are in surgical center, this will be the cost. That will truly help the consumers to make a decision. Because not only the surgery, many other fields, including, hip surgeries, knee surgeries, and the chemotherapy, what we do is very different what we paid in the hospital outpatient.
If I may, Stefan, so we made the decision to only show inpatient procedures for what we call shoppable procedures, shoppable episodes in this iteration. It would be misleading if we blended together inpatient and outpatient episodes for the same intervention, because we would be then picking up the blend of inpatient and outpatient by hospital, or potentially outpatient only if we included ambulatory surgery centers. But that is a goal for the future in which we would be able to array for hospitals that have both inpatient and outpatient, separate those as well as include completely ambulatory surgery-based interventions, so that consumers could make a comparison across sites of care when appropriate for them to receive the care on an outpatient basis only. We understand your point. I think that's a good one, Dr. O'Connor. But we wanted to show here for consumers the purely inpatient procedures only. 18 and 19 will look at that differently.
And we will also highlight this in the trend report, because we will be able to stratify the outpatient procedures from the inpatient, so we'll be able to highlight those as well. There as well.
So I see it looks like we're up to eight bundles of procedures so far. What is our plan to expand it? I think the folks that come up with these bundles have, like, am I wrong? Is it like 90 or 70 total different procedures that could be calculated this way?
So we are now at 10. We have 10 episodes. And the groupers can generate a lot of episodes. The numbers can vary 40, 50, and up to 90, but some of them are chronic episodes, so they can't be attributed to a hospital. So since this is geared towards consumers and more of like shoppable procedures, we need to identify different ways of how we could report those chronic episodes. So these are like for procedural episodes, the list is smaller basically. So max could go until 30, unless we change the approach of, we're not looking at procedures that could be at hospital, then that could expand the number of episodes that we could report.
And the reason I ask is I think this is wonderful information. It's just because it's 10 scattered procedures, it makes it harder. Like, you can sell a comprehensive list to people, go here if you have a problem, whereas you have to remind people of the 10 reasons to go here. It makes it I think more of a challenge to get it out there to the people who need it. So I would love to see, the more we can get on there to sell it as more comprehensive view, the more useful it'll be to everybody. It's very good information. I also have one other question about these bundled episodes that these folks put out. The folks that provide these are also used for value-based payment systems and other things. And are we doing anything with the HSCRC to incorporate the fact that there are wide disparities between hospitals and how expensive these procedures are with respect to setting hospital rates or budget. Like, is there any feedback from what we're doing here into their rating and budgeting process?
Ben, have you heard any feedback?
Yes. We are, and I think to the point that you're raising, Commissioner Sargent, there is greater awareness that post launch of the total cost of care model that there needs to be greater alignment across hospitals in the cost of episodes. This particular episode grouper is not the one that's being used. An alternative one maintained by H-Metrics is used by HSCRC, but Ken and his team are working with folks from HSCRC to crosswalk those. More to come over the next 6 months. I think that HSCRC is recognizing that as a result of global budgets, there's greater dispersion in specific episode prices as a result of some of the buggeries of PBRs.
Thank you.
Thank you, Mahi. If there are no other questions, we can move on to agenda item number 5.
Okay.
Go ahead. Yeah. Did somebody have a question? No. Okay. The Center for Medicare and Medicaid Innovations, or CMMI, has requested the Maryland Primary Care Program to submit recommendations on a proposed Track 3 by late August. CMMI has specifically requested that MDPCP suggest modifications to CMMI's Patient Care First, or PCF model, which will operate in 26 regions throughout the U.S. starting in 2021. The PCF model rewards participants with additional revenue for taking on limited risk based on actionable healthcare outcomes. The MDPCP leadership asked the Advisory Council to develop Track 3 recommendations. David Sharp, Director of the Center for Health Information Technology, and Melanie Cavalieri, Chief Innovative Care Delivery, will provide an update on the MDPCP and overview development of a Track 3 proposal. David and Melanie, please proceed.
Okay, thank you, Mr. Chairman, and good afternoon, Commissioners. Staff is pleased to provide Commissioners with an overview of the Maryland Primary Care Program and an update on activities underway related to an optional Track 3 program. As you may recall, the MDPCP is a statewide advanced primary care program that was launched in January 2019 by the Maryland Department of Health in collaboration with the Center for Medicare and Medicaid Innovations. The program aims to make strategic investments in primary care practices and build an infrastructure to prevent and manage chronic disease. Next slide. The MDPCP is a voluntary program that promotes broad-based health care transformation at the primary care level. In the first performance year, 380 practices and 220,000 Medicare beneficiaries participated in the program. In 2020, the number of participating practices increased by 96, and Medicare beneficiaries grew by 109,412. The program includes 25 care transformation organizations, which hires and manages an interdisciplinary care management team capable of furnishing an array of care coordination services, such as pharmacist services, health and nutrition counseling services, behavioral health specialist services, referrals and linkages to social services, and support from health educators and community health workers. Entities that may qualify to be a CTO include health plans, accountable care organizations, managed service organizations, clinically integrated networks, hospitals, and other practice support organizations. CTOs are unique to the MD-PCP program, which was generally modeled after CMMI's Comprehensive Primary Care Plus program. Next slide, please. This slide is intended to provide commissioners with an illustration of practice distribution across the state. The map is from 2019 and depicts that all counties were represented in the program starting in year 1. Next slide, please. I will now turn the presentation over to Melanie.
Thank you, David. Good afternoon, commissioners. Can everyone hear me okay?
Yes.
Thank you. So for the program roles, so supporting the program are the MD-PCP Program Management Office and participating care transformation organizations. The PMO is a state entity that provides operation support, policy guidance, education, technical assistance, health IT implementation guidance, and communication support to participating practices. David mentioned the services provided by CTOs. CTOs assist the MD-PCP practices in meeting care transformation requirements such as behavioral health and medication management by providing specialty services that would be difficult for some primary care practices to render independently. Next slide, please. On request by the Secretary, MHCC convenes and co-chairs the MD-PCP Advisory Council. We worked with the PMO and HSCRC to organize the council, and our role is administrative and to provide support. The Commission approved council members in the spring of 2019 in consultation with the Secretary, and a membership list is provided in the appendix. Next slide, please. Specifically, the Council is responsible for serving as a source of expertise and advice on matters related to the MD-PCP. Some examples may include gathering data on patient satisfaction, opportunities for expansion, and program successes, evaluating program performance and operational data to make recommendations for improvement. The Council may also make recommendations for the state's annual report to CMS. Next slide. In the past year, the Council has met 4 times to discuss program operations and provide input to the PMO. Council discussions around care delivery and reimbursement enhancements to Track 2 of the program and a potential Track 3 framework led to the formation of 2 subgroups in January, the Innovative Practice Alternative subgroup and the Practice Reporting subgroup. Each subgroup met 3 times before the COVID-19 state of emergency when council activities were put on hold. Since that time, a committee has been formed to develop recommendations for a proposed Track 3. Next slide. So the PMO has worked closely with CMS to establish the MD-PCP and is now responding to a request from CMMI to provide recommendations for a Track 3 based on the CMMI Primary Care First, or PCF model. The PCF model is an alternative payment model that aims to reduce avoidable inpatient hospital admissions and improve quality and access to care. The approach to developing recommendations for an MD-PCP Track 3 is to align it closely with core PCF model components. More information from CMS on the PCF model is available in the appendix. Next slide, please. The Track 3 committee is made up of 7 individuals representing several stakeholder categories, as well as MHCC and PMO staff. They plan to meet 3 times in early August to develop Track 3 recommendations. Then the recommendations will be presented to the full Advisory Council for deliberation before they're shared with CMS. Next slide. The objectives of the committee include identifying meaningful quality measures aligned with the state's population health goals, reducing practice administrative burden, and developing an optional payment structure that includes 2 payment tiers, a population-based payment that includes a performance-based adjustment and a flat primary care visit fee. Next slide. As briefly stated before, the committee recommendations will be reviewed by the advisory council in mid-August, after which they will be submitted to the secretary and then to CMMI. We expect that negotiations with CMMI will take place in September. Staff will provide an update to the commission in October regarding the proposed model submitted to CMMI for approval. At this time, I'm happy to answer any questions.
I have one. This is Commissioner Sargent. Looking at these programs, I guess the three things that I'd be concerned about if this were going to work or were not going to work is I don't see anything in here that gives the primary care doctor the ability to address the relationship between specialists and the sickest of their patients. In other words, the primary care program, automatically some of the sickest people are actually just bypassing primary care, going right to the specialist, and the primary care doctor might have some recommendation ability, but are we giving the primary care doctor any tools to understand what's going on with the specialist, understand who's the expensive and who's the inexpensive specialist, come up with alternative, less expensive courses of action? And I haven't seen that in any of these presentations.
So, Commissioner Sargent, this is David Sharp. Thank you for the question. So I have I'll try to keep it tight, but the answer can be a bit long. So there's two things you're bringing to light. One is, does the primary care provider know that the patient is bypassing them and going directly to a specialist, or maybe just to an urgent care center? And some of the things we'll be talking to the commission about later is the potential of expanding the use of electronic notification alerts that would signal to the primary care provider that their patient showed up in, say, an urgent care facility or in a hospital or at the specialist office, so they can get engaged, ideally within 24 hours. When there's, under the program as it exists today, when they do have knowledge that the patient sought care outside of the primary care practice, they're supposed to follow up, depending upon the setting, within 24 hours or in 3 days. So there are some requirements when they are notified, but I think you're bringing to light a point which is probably a little bigger, is in cases where they are not notified. And so we're going to try to close that gap with technology.
And then another area where it seems that these have fallen down is are in the various lists of rules and the process and the procedure we've laid out, the primary care doctors often are losing track of exactly what it is that they're supposed to do, right, in their practice. They want to be able to tie the 5 things they do to an incentive payment that comes in the door. And to the extent they can't connect what they're doing to the payment, it sort of becomes watered down. And I think what you see on upside only models is, sure, there are some doctors that sign up and they don't do anything just to collect the upside payments, but there are other ones in there that aren't quite sure what it is they're supposed to be doing, so they wind up not really changing their practice because it's not very clear. How are we addressing that, the clarity between the measures and the metrics and the incentive payments and the doctor's day-to-day, what they should be actually be doing?
So the answer to that is there is no perfect magic bullet here, but a few things are occurring. The practices have care managers, and the care managers follow the patients and follow the program requirements. When we think of the MDPCP, there's process and structure, and the care managers provide that process and structure to help keep the physicians on point. There's also, if there's a CTO that's being used, the CTO, depending upon the track you sign up for, if you sign up for a certain service, the CTO will provide a lead care manager assigned to that practice that also helps keep the structure. If you pick another model, then they provide support to the care manager that the practice currently has. And the CTO program uses a 1 care manager to 1,000 ratio of Medicare beneficiaries, so you can conceivably have more care managers assigned. But that tends to be the approach, is to provide structure via the care manager.
So I'll just add this. So the 2 tracks that we have today, track 1, there's downside risk at all. track 2, there's, depending on your viewpoint, there is some downside risk. Track 3 would impose some additional risk on the practices. And should this go forward, track 1 would disappear. I think the struggle that the MDPCP program has as it relates to Maryland is how does this play into the framework of the total cost of care gates or hurdles that hospitals have to meet that has been a kind of an ongoing debate within the advisory council as well as at HSCRC with a viewpoint from the standpoint of primary care advocates that, hey, we've invested so little in primary care. You may recall that OSE did present a paper in, I believe it was April, that showed in Maryland about 4.5% of commercial spending went to primary care, very low. In Medicare, it's lower still. They would argue that we need to invest more still in primary care. That somewhat collides with the total cost of care model in that we are really held to a overall total spending benchmark in which we all have to be, to use an overworked adage, rowing together. And the push to move to track 3 is really, I think, recognition that primary care practices are becoming more advanced and their ability to control utilization of their empaneled patients. But 2, recognition on the part of our broader health system that we need to work to engage primary care practices in absorbing risk consistent with what other providers in the total cost of care model are experiencing today. I think that's where the tug and push and pull will go as we develop track 3, that there's agreement that practices can do more to address some of your concerns. Putting them at risk is a vehicle, a sledgehammer, you might say, to do that. Just how much and how quickly is going to be the debate that the subgroup is going to take on and try to work to reach some agreement on that. Keep in mind in Maryland that the MDPCP is a variant of the CPC Plus program nationally, which David pointed out there are 26 regions of the country involved in the CPC Plus program. Only in Maryland is that program a Medicare-only program. So we really look forward to working with the commercial payers as well as Medicaid in bringing greater alignment in the incentives under this program into full operation. I think that track 3 is going to provide some additional incentives to try to do that. A representative from Care First as well as a representative from Anthem actually serve on the smaller subgroup, and both of their input is invaluable.
Thank you. I think on the risk part, it's probably more of a comment than a question. Do we have enough risk? I think having the risk built into that model, to me, seems necessary rather than like the higher level that you're never going to get there with a one-sided incentive program. Docs will take the flyer on participating or not participating, and when it gets too tough, they'll drop out. It's human nature that we want to avoid loss. A little bit of loss is much more traumatic than foregoing a gain that we never really had in the first place.
That's why track one will disappear in
But just to
2021.
be clear, Ben, that what percentage of the current providers are in track 1, track 2, track 3 have progressively increased risk? What percentage of the providers are currently in track 1 versus track 2?
So today we have about 10% of practices in track 1, and then of course the 90% in track 2, and then track 3 is still to be determined once the model is developed. But the idea here is that practices in track 2 can voluntarily take on more risk in track 3.
So it's 90% are in track 2 already?
Correct.
Wow, okay.
And what percentage of the providers in the state are in it? I mean, it's still a voluntary program.
So, yeah, we have like 486 primary care physician practices that are in the program. It started with 380. Oh, I'm sorry.
And how many do we have in the state? I'm not sure if I saw that number earlier.
So I'll give you a soft number in terms of primary care practice, or just I actually have to look that number up for you. I can give total practice counts off the top of my head, but I don't recall.
And you know what would be a better number probably? Would not, rather than absolute numbers of doctors, it would be like what percentage of the patients are attributed to doctors participating in the program. You know, how much coverage is there if it's, you know, rather than just the sheer number of doctors.
So in the program today, there are 486,000. I think that was the number I cited a few minutes ago. Hold on, I can just tell you. It started with in year 1 at 220,000. Now we're a little over 300, like 286,000. That is Medicare beneficiaries.
Other questions for David or?
This is Commissioner Bhandari. Commissioner Sargent brought a very good point that, this primary care should know which specialists are less expensive, which are more expensive. I think Blue Cross Blue Shield has similar kind of model, but it's very complex because majority of specialists are now being employed by the hospitals. So their cost of care is very, very inaccurate. It's not very accurate numbers, and the independent practices numbers are more accurate, and they being labeled as high cost doctors, which is not very accurate. I think this is something we should look into that. I'm so happy Commissioner Sargent brought this into attention.
Yeah, and just as I stand corrected, it's 329,412 Medicare beneficiaries.
This is Commissioner O'Grady. Can I ask a question as well?
Yes, please.
I think that Randy has a very good point, Commissioner Sargent does, about, because most of the work I do works with the chronically ill. And it is quite true, especially in large populations and expensive populations like the diabetics, that there's a quick moving after diagnosis to a specialist, normally within a year or two. And so it's not only the high cost cases, but it's even just the more experienced people who have sort of, we want them to be prudent consumers, and they've gotten better at understanding their own disease, and they're not getting the kind of feedback from a GP that they're looking for. So I'm a little concerned that the way the incentive structure is set up is that just so that dynamic of how does a GP control costs under this sort of situation. And it looks to me, and certainly correct me where I got this wrong, that we're setting up an incentive for the larger practices. If that specialist and GP are part of the same payment system, if they are part of a larger group practice, I can see that working out fairly well. The way we saw in rural payment, some of those large groups like Geisinger being able to work through the incentive structures effectively where smaller 1 or 2 person practices couldn't. And that may be fine. But again, we went in the last year or two through this thing where we got very kind of concerned about hospital consolidation and the growth of hospitals. but we had set up an incentive system that wanted to reduce costs, and the kind of logical outcome of that was consolidation of hospitals. So if what we think is we're taking a model that much of the Medicare style is thinking things like large group practices out of places like California, and we're setting up an incentive system in Maryland, we need to just be aware that there is some possibility that we will set in motion a consolidation of practices as well. And that what we'll see is big physician practices, the same way we see kind of bigger hospital networks now. And that may be fine. That may be fine. But we shouldn't be unaware of it or complain about it later if we set up a set of incentives that have triggered it.
So thank you.
Very good point. Yeah.
The way the program is structured, I mean, it specifically aims at practices, and the practices is supposed to have a good warm handoffs, if you will, scenario set up, but there isn't any drive for practice consolidation. That's not conceived of in Primary Care First, and it certainly hasn't been throughout the program that exists today in Maryland.
Yes, I guess I'm arguing that it can be an unanticipated consequence. That if you're saying to Randy's original point, what do you do about when they don't go to the GP anymore? They've got a fairly serious disease. It's expensive, and they go right to the specialist they've been working with for years. So how do you control that if you're a 1 or 2 person practice? You don't. If the specialist is part of the same 200 physician practice that all operates out of a big office building in Bethesda, well, working out between what's going on with the GP and the specialist is, they're all paid by the same organization. I'm not saying that anybody intended this, but I don't think anybody intended to have hospital consolidation be a policy goal of the other sort of steps that have been taken over the, ACOs. But it did set up a set of incentives that made hospital consolidation sort of one of the few tools available to meet the other policy goals. And so it happened. And I'm not saying it's a bad thing, but I'm just saying if Randy's right, and I think he is, we're setting up a set of incentives that are going to make mom and pop operations harder and harder to be able to work with us. And as he pointed out, they'll just drop out. And the big guys who can sort of organize this and get the payments worked out in-house, I think they'll do very well under this program.
So if I was tied up with some audio issues. I'm hoping that Commissioner Boyle is back on now. But I think you're right that the advocates for preserving one-sided risk point to those very same reasons that small practices can't take two-sided risk or are hesitant to do so because they are very small. So I think it's a tough, how do you move things along so that maybe you have a practice consolidate somewhat, but not feel as though they have to affiliate with a large system to survive, is what here in Maryland some of the primary care advocates have thought about, that it's better to be in Montgomery Primary Care than affiliated with Healright Health Systems, Dr. O'Grady. But all of this is hypothetical. The whole framework of the program aligns with CPC Plus, and we are moving towards two-sided risk for primary care, even small primary care practices. And I think small ones are going to struggle unless they are affiliated at the minimum virtually, but more likely more fully operationally affiliated with a large system, be it system or an ACO.
So one point, this is Commissioner Sargent, one point to think through is that also the other part of my comment is, what are we giving to the primary care doctors that lets them be more effective in that circumstance, right? So I was asking, are we giving them information about the specialist? Are we giving them ways, templates that they should be following? If you have this patient and this is that, and we have a care coordinator, I know what I should be doing to try and help get in and manage that care where I otherwise would not be. Because if we have to give those primary care doctors something to be effective, whether it's additional information and the resources. So I know we have the care managers, And the question would be whether they all know what they should be doing in that case, and if they're all doing it uniformly, or are we having 1,000 flowers bloom, which would be great for some of the flowers will do quite well, and some might not. But that was the other part of my, I think, comment with that.
Thank you, Commissioner Sargent. There is a structure. It's not perfect. I think there's some reason to be mindful that there can be a fair amount of deviation at the practice level. But I think the point is that the program management office and the CTOs work closely with these practices to try to keep them sticking to, if you will, the fundamental criteria that's aligned in each track. And if I might, I would like to take this opportunity to correct myself for the chair, Mr. Chairman and Commissioners. The percentage I inverted in track 1, it's really 90%, and track 2, it's 10%. My apologies for the inversion.
So that's what I thought. That's why I asked the question. So it's if it's 90% in track 1, and
yes,
as we increase the risk to track 2, we get to only 10% of practices signing on. Why do we think that adding a track 3 that will take away track 1 would be a good idea? Why wouldn't that just cause 90%? How do we know that that won't just cause 90% to drop out entirely?
So they're supposed to, even without a track 3, they're supposed to progress to track 2 over a couple-year period. I mean, the program requires you to monitor
3 years.
So you actually have to end up there. The track 3 is optional, and it's supposed to be for practices that are more advanced. And the idea is that over time, even the practices that are less sophisticated will be able to pursue it as an option if so choose to.
Before we leave this, I just wanted to point out that some of the CTOs are actually practice independent ACOs, and they've actually done a pretty good job of providing information on high-performing specialists to their participating primary care providers. It's more challenging for CTOs that are hospital-based, but I have heard, without naming systems, CTO operators talking about thinking more broadly as they refer primary care providers to the most cost-effective specialist, both inside and outside their system. So there is some thinking about that. I think the view that there's vertical consolidation is probably a much more powerful incentive than what's happening in this program, but particularly the independent CTOs, the Allidades, the Previas of the world, they do have that information, and they're much more aggressive about highlighting it to their primaries on where the best value is.
Mr. Chairman, this is Commissioner O'Grady. One last question on process. The proposed timeline that's up on the screen now it has everything going on, including recommendations going to the Secretary and then negotiations with CMMI before our commission ever sees this again. We are simply reported back to after the fact. Is that appropriate? Do we have no real authority here over these recommendations? Are we just being kept in the loop as a courtesy? Or is this, I'm just not sure what our role is here.
Yeah, it's a good question. My understanding, and I'll let Ben weigh in also, my understanding is the authority here rests with the PMO and with the Secretary, and that we're being kept in the loop as a courtesy and for input at this point. But we don't have the authority over this program.
Right. So we're organizing this sort of and housing it a little bit as a professional courtesy to the Secretary.
We're reviewing it right now. We're not housing it.
Okay.
Ben, is that correct?
Yeah, that's correct. And I think we tried to open this up a little bit to the commissioners. The chair of HSCRC and the chair of MHCC have had a number of discussions with the Secretary about the appropriateness of MHCC controlling the program. I think the health secretary felt very strongly that one of his own objectives was to foster and further primary care in the state of Maryland, and he contended that it would be more appropriately directed under his office. So consistent with our applications, we agreed to support his efforts. I think his both intellectually and emotionally, his heart and his mind are in the right place, but it does, I have to say, limit our ability to shape the program the way we would absolutely like.
Yes, and I don't have any problem with it. It's just we won't weigh in again until it's a done deal. And so if we had any recommendations, they're moot at that point.
And I think one of the things that we are getting some feedback on is that CMMI may be changing its mind about how quickly we need to move. This was put together before we contemplated an August meeting, and as I mentioned to the staff this morning, that if we did have an August meeting, the updates on the progress of the advisory council would be on the agenda, as well as the CONs. But it's, again, I don't want to over glorify this, that it would be updates to get your input on this. One of the things I would observe in terms of looking at primary care first as a model is that leadership at CMMI has basically said, Maryland, don't muck with this program too much. And we're taking that seriously because we think, consistent with what I've heard today, that moving towards greater risk is something that probably is in the best interest of overall of healthcare reform in the state, but being mindful of what practices can be capable of is something we have to allow for, particularly smaller practices' ability to reach these higher thresholds of risk.
Right. And I guess I would just say that having been, a policymaker at the federal level, you do it based on kind of what makes the most sense at a national picture. And so it is true that other parts of the country have much larger practices, and they have patterns of organizing their physicians and other providers in different ways. So we should just know that if we are going to defer to the feds, it's going to be a little bit of a one-size-fits-all. It's going to be, if they're doing their jobs right, it's going to be the size that is most appropriate for the most states. And that may or may not line up with what Maryland wants to go. So just if the secretary is, like you say, he's very motivated in this area, and that's great. Just careful what you negotiate and careful what incentives you end up putting on the Maryland system, and be sure you're comfortable with them. I hope everybody's comfortable with large hospitals, because we've got it and it's not going away. And so with this one, the way it's been described today, and I think Randy's very good points about this, you're going to see I would predict 10 years from now, we'll look over and we'll see much more large group practices like you would see on the West Coast of the United States, because you've set up an incentive to do it for not for that particular policy goal, but you've made that the logical tool to achieve your primary policy goal, which I agree with. But it's just know what you're getting into is, I guess, my only warning.
Thank you. And I think on that front, that we have a very unique hospital-anchored system that we're now trying to fit a primary care model into. That in itself is quite a challenge. The GBR framework itself means that savings achieved to date are to some extent held within the system. And as we design a primary care and really other specialty care models as well, we have to be mindful of these kind of overarching capability of the total cost of care model as it relates to how particularly fixed costs are retained within large health systems.
Mm-hmm. All righty.
Thank you.
Other comments? Thank you, David, and thank you, Melanie. And David, I think you're still up. So on to agenda item number 6. In response to COVID-19, certain federal and state telehealth policies were relaxed and expanded. Telehealth increases access to healthcare for individuals where a traditional office visit is not otherwise possible or is otherwise more difficult. During the current healthcare crisis, telehealth has enabled patients to continue to receive healthcare. Ensuring continuation of the expanded telehealth policies is critical to improving quality and reducing utilization. On June 29th, the American Telemedicine Association sent a letter to Congress signed by 340 organizations urging congressional leaders to make the flexibilities permanent. David Sharp, Director of the Center for Health Information Technology and Innovative Care Delivery, and Nikki Majewski, Chief Health Information Technology, will provide an overview of the key policies. David and Nikki, please proceed.
Thank you, Mr. Chairman, and again, good afternoon, Commissioners. Staff is pleased to provide Commissioners with an overview of key federal and state policies that have played a vital role in the use of telehealth in response to the public health crisis and driving transformation in how care is delivered. These policy changes fostered rapid growth in telehealth as a way to provide acute, chronic, primary, specialty, and behavioral.
Somehow the conference room just got muted.
I was
There you
trying
go.
to Commissioner Boyle. She's on. She's back.
Continuing onward, regulatory relief that was implemented in March enabled providers to quickly pivot operations in support of virtual care delivery. Practices swapped nearly all their in-person visits for virtual care services to minimize unnecessary exposure to COVID-19. During the public health crisis, telehealth has been used to screen patients who may have symptoms of COVID-19, provide low-risk urgent care for non-COVID-19 conditions, access primary care providers and specialists, monitor clinical signs, and provide coaching and support for patients with chronic conditions, participate in physical, occupational, and speech therapy, extend resources and support for behavioral health and education services, follow up with patients after hospitalization, and provide non-emergent care to long-term care residents, and support to home health. Next slide, please. Public health crisis has shed light on policies that require attention that can effectively be used to transform the way care is delivered. Possibility of extending existing regulatory flexibilities and waivers are being discussed at the federal level by states and stakeholders. In the following slides, Nikki will cover the policy changes listed here that have primed the telehealth landscape for modernization. Nikki, I will now turn the presentation over to you.
Thanks, David. While these policy changes in telehealth coverage have been essential to assure patients receive safe and uninterrupted care during the COVID-19 public health emergency, equally important is having the appropriate technology to provide services remotely, which was an issue for some providers who had not adopted telehealth. This was addressed by the Office for Civil Rights that lifted through a notification of enforcement discretion back in March, certain restrictions as it relates to technologies that could be used for the provision of telehealth services. This includes popular non-public facing applications like Apple FaceTime and Facebook Messenger video chat. Effective for the duration of the public health emergency, OCR will not impose sanctions and penalties on providers that use specified technologies for telehealth that are not HIPAA compliant, provided they are used in good faith and for diagnostic purposes. The public health emergency is set to expire on July 25th. However, on June 29th, recently, an HHS spokesman, Michael Caputo, tweeted that HHS intends to extend this, which would prolong the emergency declaration by 90 days. Next slide, please. Next slide again. Apologize. One more. Great. In terms of licensing requirements, they vary across states. For Maryland, providers generally must be licensed in the state to treat patients in this state. Due to the Maryland state of emergency, which was recently extended by Governor Hogan on July 3rd, licensing rules have been relaxed to allow providers with an active license in another state or the District of Columbia to practice telehealth in Maryland. It's important to note that providers still need to check telehealth policies and make sure telehealth practice is permissible in other states by their appropriate licensing boards, depending on where their patient is located. Another important thing to note is they should also check with their medical liability carrier to verify their policy covers telehealth and under what circumstances. For example, if coverage is limited to a specific state or geographic region. Next slide. Practice across state lines has allowed providers to deliver telehealth services wherever the patient is, including their home as well as outside designated rural areas. Traditionally, Medicare pays for telehealth on a limited basis. That's when a patient receiving the service in a designated rural area or when they leave their home to go to a clinic, hospital, or certain other type of facility for the service. The expansion of audio-only visits has allowed patients to continue care with their providers. For those that had not implemented telehealth, it has also allowed those who don't have a smartphone or a computer to access care and made it easier for those living in rural areas without broadband internet. Next slide. Both new and existing patients have access to telehealth for an expanded list of services that can be provided using telehealth during the public health emergency. Typically, Medicare would have required a provider or another practitioner within the provider's practice to have provided telehealth services to the patient within the past 3 years. Next slide. The expansion of eligible providers and services has significantly increased the number of patients who can take advantage of telehealth. This includes non-physician provider types such as clinical social workers, clinical psychologists, physical therapists, among others listed on this slide. Home health and hospice providers can also provide more services as appropriate. And remote patient monitoring is another area that has allowed providers to expand their capabilities, helping address challenges of delivering real-time care without putting patients and providers at greater risk. For the most part, any provider who is eligible to bill Medicare for their professional services is eligible to bill for telehealth. Physicians may also supervise services through audio and video communication instead of only in person. Next slide. In terms of cost-sharing flexibilities, patient out-of-pocket costs have been waived or in some cases eliminated for telehealth services, typically when using an in-network provider. Like many of these policy changes, some flexibilities are subject to payer requirements and timelines. Next slide, please. As many are starting to think about telehealth post-COVID, there is considerable support to make many of these policy changes permanent. This is in part due to satisfaction expressed by providers and patients. A recent study found that 65% of consumers plan to use telehealth more after the pandemic. About 78% also said COVID-19 has shown how badly the U.S. needs more telehealth options. Some payers are beginning to signal plans to term certain temporary waivers, such as cost-sharing flexibilities. But for the most part, stakeholders feel a complete return to the prior policies is a step backwards and would have negative consequences on consumers. Discussions are ongoing to evaluate the benefits and examine which policy changes should remain. Some stakeholders plan to introduce telehealth legislation in the upcoming session. that will make certain aspects of these policy changes permanent. Staff is in discussion with stakeholders to convene a telehealth work group that would identify recommendations on how to maximize the benefits of telehealth while maintaining high patient safety. Next slide. Lastly, just want to call your attention to this slide and the next one, which includes a table overviewing several MHCC initiatives, some of which have been expanded or recently implemented in response to COVID-19. This includes the Telehealth Virtual Resource Center to help educate and provide resources to practices implementing telehealth. It also includes activities promoting consumer awareness and education about telehealth. In addition, initiatives include the development of a telehealth readiness assessment tool, a telehealth technology vendor portfolio, and also providing technical assistance to various provider types for telehealth funding opportunities. This concludes the presentation. Happy to answer any questions.
Commissioners have any questions for Nikki or for David?
It's my day to ask questions, but I have one. If somebody else is welcome to go first.
Go ahead, Commissioner Sargent.
Here's the question I have, and it's half concern, half question. Previously, before the pandemic, telehealth was sort of easily defined, at least for the commercial markets, that you needed an audio and a visual connection, and then it would be covered as long as it was a medically, like appropriate service for telehealth. And it's basically on the same terms of coverage. Now that you can go audio only or text, there seems to be there's a real concern that there are doctors who are covering their lack of face-to-face patients with things that they normally wouldn't have billed. Every time you talk to a patient now, it's a billable event, or every time you drop a text, it becomes a billable event. I don't know of any standards out there that would use to separate things that's not really a service, that you can talk to somebody for 5 seconds and it's not really a billable event. I don't think that exists. That's a concern that I have with continuing to recognize audio only, right? Every telephone call becomes a doctor visit, every text becomes a doctor visit. I don't know of any guardrails on that outside of going back to the older rules.
I thought there were clear guardrails on it with regard to the amount of time that had to be included in the conversation to get to levels of billing. Nikki or David, can you comment on that? What I've been taught about this is that there were specific guardrails around that.
Yeah. So go ahead, Commissioner Sargent. You were going to say something?
No, please go ahead.
So it is that it has to link to the care plan. It has to link to conditions such as it can't follow on the heels of a discharge in the last 24 hours. It has to be something different, and it can't lead to an admission within the next 24 hours. So there are some parameters, and it requires documentation to support the service in the electronic medical record, which in that case is reviewed, and then for coding of the claims, and then it's reviewed later on to make sure that that was a valid service. So it's a standard of care that has to be supported. You have to follow the same protocols that you would if the patient were in front of you, and the documentation that's required is consistent with what you would in the medical record if the patient were before you.
This is Commissioner Bajaj. So, as Chairman Pollack said, there is a time requirement. Is reviewing their records is part of that. For example, it takes time to review the records and make a phone call. Is the phone call is the time limit, or the whole lump sum time spent is a part of that? Because that is a big concern. Nowadays, patients have piles of records. If there is a lot of time spent on the records, reviewing, that should also be part of that, not only just the phone call.
Yeah. So just to be clear, my understanding of the rules are that that time can be included in the audio plus video visits, but not in the audio only visits. In the audio only visits, it has to be specific time spent on the phone with the patient. To Commissioner Sargent's points, he wanted to make sure that there weren't just quick phone calls that were being billed as encounters, and that there are lots of guardrails around that. It's not you can't just pick up the phone, call the patient, and send a bill. You have to generate a note. There has to be a time associated with the call itself, not the work behind the call, but the call itself on the phone that's commensurate with the level of service billed. So it's not as simple as that.
Commissioner Thomas, I have a question. Do I have the floor?
Yes. Yes,
Okay.
you do.
So you know, this is an observation. We're talking guardrails. I mean, this is rife with not being able to pass a smell test, so to speak. And the reason I raise this is because I've been in communication with primary care physicians, and they are really, really threatened by this whole sense that, voila, we've discovered through the pandemic we can do all this online. They really are thinking that their practices are going to go under. And so this scrambling that you see is just fraught with I just think if it were in the front page of a newspaper, everything we're saying would not pass the smells test with the general public. So what is the underlying root problem here so that telemedicine doesn't get caught up in a perception that is simply another way of bringing in money, but not commensurate with the service? How do we make sure that we don't get messed up on this?
I'm not sure I understand the concern that you're raising specifically.
Let's do this. Those practices that think they'll go out of business if all of a sudden everything starts moving to telehealth. So I'll let the physicians tell me. Why do those primary care physicians think that telehealth could run them out of business? So let the docs tell me that, because I'm a public health person here. Why do those physicians?
As somebody who's running a practice that has adopted partial telehealth and partial inpatient and partial in-person services right now, I'm not sure I understand that concern. Because right now, if you do a telehealth visit instead of an in-person visit, you're getting paid at the same rate that you would have for the same service in person. And from the primary care perspective, I'm not sure I understand what they're worried about, because it would seem like now they have the ability to see patients via telehealth or in person, either or. From a patient care perspective, what I hear from the patients is that it is wildly more convenient to be seen by telehealth. You don't have to get public transportation somewhere. You don't have to get in a car. You don't have to take time off of work. You just get your provider and the telehealth visit is done on your phone. You don't have to be in front of a computer. It's done on your smartphone. So the patient's perspective of this is that it is wildly more convenient in many circumstances. Some people aren't comfortable with it, and they stay in in-person visits. But I'm not sure I understand the concern on the part of the primary care physicians that they're going to be driven out of business, because they're still able to do the visit, but and still get paid for it. Is there a way to elaborate?
Yeah, it just might be companies coming in that's all they do, that they've hired a bunch of physicians. It's all telehealth. Maybe the concern is that they'll lose patient volume to these new companies coming in just doing telehealth. I just know there's tension there, and we need to just be sensitive to it.
Yeah, so I think that is a concern that others have raised. Dr. Bhandari, you've talked about this before. I see your light on.
Commissioner Bhandari, Commissioner Thomas, I echo you. You are absolutely right. There are a lot of venture capitalist companies. Those who are coming, they want to take away, and they want to do the simple, take care of patients' simple problem. When it comes to complex problem, they dump it on their primary care physician who has been there for a long time. It's really a concern. When I was on board of physician, we have same concern. There need to be some, real guards, how to make it more efficient. I echo your concern. I'm with you, Commissioner Thomas. And, Medicare still have those 99411 codes for the phone calls. They still has, the payments are very small. I hear from my primary care colleagues, and anywhere from 10 minutes to 30 minutes, the payments are very, very small. Hopefully Medicare will change that.
Commissioner O'Connor, I have a question.
Yes, sir.
Can you hear me?
Yep.
It's my understanding that audio telephone call only contact with the patient is not reimbursed. It needs to be audio-visual engagement to be reimbursed the same as a person-to-person consult.
Yeah, that
not
changed during the pandemic, and the audio only is billable at a lower level, but still billable.
Okay, yeah, it's much lower. It's almost not worth billing for it.
It's for 30 minutes only $50.
Yeah, it's not worth billing for it. Okay, that answers my question. There are some channels now to tie telephone interviews with like Epic, just to be more exact and, you know, as far as billing and the exact amount of time that you're on the phone with the patient. So I think it's heading towards, that would give better control and avoid any fraudulent stuff going on, I think.
I think that Dr. Thomas was bringing out the same point that Dr. O'Grady was talking about a few minutes ago, that the technology will squeeze out smaller practices. That what we've observed, and partly our response to that was to try to launch this small practice telehealth engagement product, was that there's a certain culture that has to be learned of running face-to-face and remote patient treatment that may be very difficult for a small practice to take advantage of, especially if there's very limited back office staff. That I think is, you know, a legitimate issue going forward. That everyone should have the same opportunity, but in reality, if you're two people with one front office person, it's going to be an additional challenge, especially if your telehealth platform is pretty limited in terms of capturing information about coverage, copays, etc. Admittedly, their copays and deductibles are in some instances waived, but it is a workflow problem for everyone, but a workflow problem that can be especially daunting for small practices. I think we have a role to play there. I think the discussion demonstrates all of the issues that are going to likely crop up over the next 6 months as we try to figure out what should be permanent, and if it is permanent, where it needs to be established at the federal level or at the state level, and what are the consequences of eliminating some of the, or rolling back some of the relaxations that everyone's growing accustomed to.
I just want to make one additional comment here on this, and that is that we have been struggling now for the better part of more than a decade to increase telehealth adoption throughout the state and throughout the country. And there have been logarithmically greater advances in the adoption of telehealth throughout the course of this pandemic than we've ever seen before. And part of that's because people can't get out and get to the doctor. And the other part is because we dramatically decreased the regulatory burden attached to telehealth. And that's an important message for all of us about the impact of regulatory burden on stunting the growth of new technology. So I think it's going to be important that we we understand the challenges ahead of us in terms of the venture capital firms and controlling making sure that patient safety is and the quality of the care that patients receive is at the forefront of what we're doing. But understanding that as we add regulatory burden, we will prevent this thing from growing and thriving, just like other things. All right. Other comments? Commissioner Thomas had to drop off, and I see Commissioner Wang has now left. We're going to move on to the overview of upcoming activities. Ben, would you like to share the upcoming activities for September, or for potentially August and for September?
The recordings we don't have those. Okay, David has one more exciting announcement on telehealth that is going to be a message that is near you in a very short future. Go ahead, David.
Yeah, thank you. The team, Nikki and others, we've worked hard to develop a lot of different education awareness strategies about telehealth. And one of them is the use of public service announcements. And what we have done is we've tried a lot of different organizations, but we ultimately ended up getting Jim Palmer, who was a former Oriole player, to do a public service announcement where he talks about the value of telehealth, and that he also acknowledges that he talks about the Maryland Healthcare Commission. And we also have a current catcher, the back catcher, and I think his last name is at Waynes, who is the current player of the Orioles, also did a public service announcement recording. We will be distributing them around to local radio stations. Giant has already agreed in its 308 stores in Maryland to broadcast these messages over their store radios. So we'll be looking for ways to distribute that as public service announcements. And so we thought we'd be able to share the recording today, but we can send them out electronically.
Thank you, David. That sounds great.
So for as Dr. Pollack has said, we're going to try to make a call on the August meeting over the next 2 weeks. We'll try to do that more quickly. We would expect at our next meeting, August or September, that we would have several CONs to bring before you, several hospital CONs. If you like the discussion on primary care, regardless of that is in August or in September, I can promise you there would be more to come on that. And we would be also planning to update you on some of the quality initiatives going forward, as well as progress on state health plan development, particularly the acute psych chapter of the state health plan. Thank you very much.
Questions for Ben? Hearing none, I will entertain a motion to adjourn.
So moved.
Second. All in favor?
Aye.
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 Thanks, everyone. We don't meet in
Thanks,
August.
everyone.
Have a wonderful summer. Take care.